Very new procedure. I think everybody should come and see this. Good morning, everyone. Good morning, sir. Good morning. So, today's presentation, I'll start with paying tribute to Lata Mangeshkar ji. A very sad demise yesterday. A big era has ended. The complete Bollywood industry and the times which we have crossed, I think we can never hear her voice again. So she was a true legend. So my tribute and my condolence to her family, and it's a great loss for the nation. Bharat Ratna Shri Lata Mangeshkar ji. With this, I'll start my presentation today. Today I am speaking to you about hemoperfusion, which is actually a relatively old but relatively newly applied technique. Now this procedure has been there since 1940s, and actually it has come into clinical practice since 1970s and 80s, which we are using it at a more frequent level. Okay. So now you have seen what is dialysis, you have seen what is hemofiltration. For those who don't know about hemofiltration, now we just have various types of dialysis. It's not just the hemodialysis which we are doing. There is a procedure where we actually use a replacement fluid which is called as hemofiltration, and we combine hemodialysis and hemofiltration, that is called as hemodiafiltration. And there are procedures you have heard of, often maybe you have not seen here, that is called as continuous renal replacement therapy, or CVVST, also called as CRRT. So those are the techniques, and they have their own use and advantages and disadvantages. Now if you see hemodialysis, it is good for removing small, now to talk to you on a basic level, when we try to remove solutes are classified into low molecule, middle molecule and large molecule solutes. So what we are doing in dialysis, we are able to remove small molecules, little bit of middle molecule, we are unable to remove major middle molecules and large molecules. So for those procedures, we need a better procedure, better dialyzer. So those are called as high flux or hemofiltration or hemodiafiltration. Sometimes even in CRRT, but the problem with the other procedure, it's expensive. You need a better RO system which can give you ultra pure water, because there will be more interaction of water and blood when you are using a high flux or a high pore dialysis. Now the topic for me today is talking about hemoperfusion. Now hemoperfusion is something different from hemodialysis. Now in the word dialyze means to remove. So you are trying to remove something. In this case are electrolytes and solutes. But in hemoperfusion, it's not dialyze, it's actually perfuse or adsorb, means you are trying to absorb, just like tissue paper, or you are using something as an absorbent column. Here you are using a material which can adsorb or take inside something which you want to remove, and that is hemoperfusion. Now what it exactly is, now all this is coming under extracorporeal therapy, means the therapy or treatment which we are doing outside the body. Now it's a blood purification system which you all understanding. Now in this we are actually passing an anticoagulated whole blood through a device which is usually a column which contains an adsorbent particle, and it is used for removal of what? Toxins, poisons, and it can also remove cytokines and interleukins in case of septicemia in some centers, but that is under trial. So what is the exact mechanism? The mechanism is the whole blood is passed through a column that contains an absorbent particle, and that particle has to have a weight. So whatever is the particle, or you say it a toxin, should be between 100 to 40,000 Daltons, which binds to these particles which is there in the column as an absorbent material. And when you pass the blood, when blood exits through this column, and that is absorbed into this material. High molecular weight solutes are less absorbed efficiently. For this you need a better format. Sometimes you may have to combine dialysis with hemoperfusion to have better efficacy. I will be talking on that in the subsequent slides. Now these materials which you are using are either charcoals, which we are classically using, and now we are going into resins. Resins are more modified more molecular specific, more particle specific material which less which more biocompatibility and less chance of embolism. So, that is what resins are now coming up, and these are basically polysterenes. Now, previously what we are using is the when I was also a trainee, I was using charcoal. Now, what is charcoal? You are using charcoal for gastric lavage, the same principle is over here. Now, what this charcoal is doing is basically all those water soluble molecules get stick to this charcoal, whereas resins, when you are using the newer one, which you can use lipid soluble molecules. So, when you have a molecule which is more of lipid soluble, for example, paraquat, there a resin will have a better performance. And whereas you have molecules which have like amphotericin B, and there are molecules like vancomycin, those are more water soluble, their charcoal will be more efficient. So, you have to know properly which molecule you are going to remove. So, this absorbent may be modified, and you can selectively use for various toxin. You can use it for sepsis, you can impregnate with antibiotics, you can use it for bile acids, you can use it. Now, that is actually opening up the spectrum of treatment for various critical care critical illnesses. Now, I will just show you through this diagram. Basically, on one end, this is a column, on one end the column consists of this resin. From one end we are passing the blood. Now, when the blood crosses through it, now this is size specific. So, there are size of small molecules, for example, RBCs, proteins, they will cross. But when you are using the aim molecule which you need to remove, there are sieves inside this resins, and that will try to absorb it or stop it or just bind to that part of the molecule. And then we have other protein bound molecule where we also have that molecule bind, that also can be stick to the resin based on how you engineer your bioresins for this charcoal filters. Now, previously we were using charcoal, then we came into neutral macroporous resin. Now, we have anion exchange resins. Now, the modified version of the cartridge which now is coming up, you can actually use for hepatotoxins, you can use for liver dialysis, you can use for bile acids, you can use for bile salts. So, that with septicemia. So, if you have a liver failure with septicemia, you have a modified cartridge which can be used for that particular molecule. Now, how did this charcoal go into the resin? Now, charcoal has various problems. Now, it has low middle molecule clearance, where you can actually have a better middle molecule clearance if you are using resins. Secondly, being a charcoal, it has a poor biocompatibility, so more chances of allergy. It can be harmful for blood cells. It can also break because the skeletal is not strong of the cartridge. So, it can break, and that can cause charcoal embolism. So, these are the risks involved using charcoal, for which the newer macroporous resins have come up. Now, they are better molecules, they are better suited to the blood, they have a better compatibility, and they sieve like you see in this diagram. Basically, they have various molecular targets or the weight targets, where they get the molecules go and get stuck. So, they cannot pass across the barrier or the resin barrier. We have just discussed this. So, talking about hemoperfusion, now there are various indications. Now, this indication should come as a thought when you are receiving a patient with an acute poisoning for any drug or toxic. Now, if you do not have any specific antidote, for example, paraquat, for those patients which has a very high mortality, you can think about this modality for treatment, and it has to be done as early as possible. Then blood concentration of the drug or the poison has reached a lethal dose, more than 20 ml, more than 20%, that is the lethal dose for paraquat. For any drug, that then this should come under consideration for use. Blood purification clearance rate is higher, means your normal kidney functions are not there, and your excretion mechanism is not enough to remove the molecule from the body. Drugs and poisons on the internal environment is causing the effect, means the renal failure is happening, the liver failure is happening, poisoning patients with liver and kidney disease. Intake of an unknown composition, you do not know. Most of the time we are blind about the composition, blind about the volume, blind about the numbers of blood tablets. In those situations, you have to take a call early. dose exceeding 30% of the scavenging capacity of the body. These are the situations which you have to consider using hemoperfusion. Now, what are the actual indication? Now, there has to be something which is more ideal, a molecule which is more ideal, more lipid soluble, highly protein bound molecule may not be very useful, because you have little bit of less than 80% protein bound is more preferable. But higher protein bound molecule you have to use in combination of something like a high flux, combination in something with plasmapheresis. That time you can actually remove protein bound molecules also. So, these are the classical indication which you all have used in past: paraquat poisoning, barbiturate, theophylline, valproic acid, carbamazepine, and aluminium with after chelation with desforaminine can also be used. Now, it is a huge list. I am not going through this list, it is available. You can go through various articles where the molecules which can be removed, but the common ones which we are using and the commonest where we are using hemoperfusion is something called paraquat. Now, paraquat has highest, I think it is comes under the number 10 most lethal drug which is available to humans, and it has a very high mortality. Some places, some literature, it has report 80 to 100% mortality. So, it is an important thing to discuss today. Now, hemoperfusion has come up, it has provided better early clearance of paraquat compared to high flux dialysis, and there are several retrospective studies which have shown that hemoperfusion is associated with greater survival. I will go through those studies also, but if you use as early as possible. Now, hemodialysis or CVVHT can be used in combination, and there are studies which have shown that if you use in combination, it works better than if you are individually choosing hemodialysis or hemoperfusion or a conventional therapy for the drug. Now, if you see this diagram, it is not a diagram, it is a picture, and this is a grass, and this grass is almost half burnt out, and this is what paraquat does to the grass. And you all know paraquat is it's a household commodity in rural India. It is available in everybody's house if you go to rural India, because it is used as a herbicide. It is used to remove or burn out or remove the crops before the next crops can be harvested. So, it is there in the house. So, and the problem with the rural India is there are farmers who are under debt. So, there is increasing incidence of suicides which is occurring in our rural India, which is a concern now. So, and this paraquat is taken and they go to rural hospital, and there the things get delayed, because when they reach the tertiary center, they have already crossed around 48 or maybe 72 hours or even more. So, then you lose the window to treat these patients. So, it is used in the crops to kill this grass, and there has been several agitations to ban this, because this is a human lethal molecule which is available, easy to procure. Today, at least more than all the European countries, Sweden being number 1, they have all removed this, they have banned this drug, but it is still a part of Asia Pacific. It is available in India, and do you know the global market, the profitable market of this drug? It is approximately $107 million US by 2019, and it is going to grow to $53 million by 2026. So, that is the huge market, the money involved in the business of this, and that is why you be ready to have more patients, because this is going to be used more and more. So, that is why today's topic I choose, because this is going to be an upcoming challenge if you are facing this kind of patients who are coming with paraquat poisoning. Now, coming to the prescription of hemoperfusion, how you are going to design the prescription of a hemoperfusion. Now, as usual, you need a line which has to be a dialysis line and a dialysis apparatus which has to be used, and generally the charcoal volume which you are using is around 100 to 300 grams, or the resin volume which is around 300 to 650 grams which you are using. And the access, you can use a tunnel or a non-tunnel jugular or a femoral, which is easy for that particular time for you to insert. Selection of the cartridge, now it depends upon the body surface area and the drug involved, but normally we don't have much choices. We have single size cartridge which usually holds a volume of 150 to 200 ml of blood. And the anticoagulation which you are going to use is the commonest, which is heparin. You can also use regional citrate. Dose of heparin will depend upon a ACT level which has to be maintained between 2 to 2.5 times of normal. Activated plasma thromboplastin time should be around 60 to 70 seconds. Approximately you will be using around 6,000 to 10,000 units of heparin. So, if you have bleeding issues, then you have to be very careful using it. Then the blood flow, you understand what is the blood flow? When we are using the machine, there is the circular fan inside the machine has a speed, and that is called that can be adjusted, and that governs the type of dialysis. When you talk about sled dialysis, basically you are reducing the speed of the fan, which comes to around 100 to 150. So, what is the speed of blood flow? There the hemodynamic component also lies. The higher speed you go, the more chances of having hypotension during the procedure. So, normally it is around 300 ml per minute. Blood flows should be increased approximately to slowly to 450 depending upon the hemodynamic status of the patient. What is the duration? Normally we use it for 4 hours. First 2 hours is the most crucial, where we have the maximum poison removal, and followed by the next 2 hours. Reuse is not permitted, because once the molecule of the resin gets adsorbed, you cannot use it again. Unlike dialyzers we use again 6 to 8 times, hemoperfusion cartridge is a one time use. Repeat treatment based on your drug levels in the body, but drug levels it takes time, so you have to take your clinical decision. Normally we use 1 to 2 times of hemoperfusion in cases where there is a lethal dose taken. So, drug level is the most important thing to monitor if it is available to you, but it takes too long to have a clinical usefulness of the modality. So, you have to start hemoperfusion based on the history of the suspect history, and the clinical response should guide you the therapy, how long, how much, how many you have to give. Platelet count is the one thing which has to be monitored regularly, because you can have thrombocytopenia following the procedure. This is a typical circuit of the hemoperfusion dialysis. Hemoperfusion starts, you see this is the blood pump, this is where I was talking about the speed of the machine, and this is the anticoagulation chamber. We anticoagulate before the blood enters the cartridge, and this down the line is the cartridge where the blood enters from the lower end and then exits from the upper end, and then it goes back to the body. If you are using a dialysis in combination with hemoperfusion, then you have to use hemoperfusion upstream of the dialyzer. I mean, it should be used before the dialyzer column. And this is the picture of a hemoperfusion going. This picture is from our hospital. Now you see this is the hemoperfusion cartridge. This is our patient undergoing hemodialysis. This is the dialyzer cartridge. So that is how the circuit goes for a hemoperfusion or hemoperfusion with hemodialysis. What are the complications? Thrombocytopenia is one thing which I have mentioned to you, and usually it is not very dreaded, because normally platelet counts comes to normal within 24 to 48 hours after hemoperfusion. Other things are hypocalcemia, hypoglycemia, neutropenia, because of they can also have charcoal embolism. There may be mild decrease 1 to 2 degree in the body temperature during the procedure, and hypotension, which is the most common thing. We have to be very careful when you are using vasopressors. You have to use this vasopressors distal to the sorbent material, that is distal to the hemoperfusion cartridge, because that may get absorbed. So, their efficacy may reduce. So, you have to use it after the hemoperfusion cartridge. Now, talking about the combination hemodialysis plus hemoperfusion. Now, hemoperfusion does not remove fluid, as I told you. It is a absorbent column with the only job it is absorption, but it cannot remove fluid, it cannot correct electrolytes. So, if you have a status where you have acidosis, we have renal failure, you have to combine it with a modality called hemodialysis. So, hemodialysis will help you to remove fluid, correct electrolytes, correct hyperkalemia, And among patients with acute kidney injury, which is common scenario in paraquat, hemodialysis is always required. Hemodialysis may be performed first, following immediately after hemoperfusion, because you have to save the patient first. If you have hyperkalemia, you have to correct hyperkalemia first, then you can take for hemoperfusion. But if you have a crisis situation where drug levels are high, BP is low, you have to perform it together. In that case, you may use it together. How I have shown you in the previous picture, you can do that we did with the last patient. Alternatively, hemoperfusion may be combined with CRRT also. We don't have a CRRT over here, but it can be used. CRRT is a longer procedure. If you have hemodynamic compromise, you can use CRRT with hemoperfusion. So, hemodialysis is used greater than 95% of patients in whom extracorporeal therapy is employed to enhance the protein elimination. I will tell you how. Now, it is just not hemoperfusion. If you are adding hemodialysis, you actually enhance the poison removal. During hemodialysis, up to 400 ml of blood per minute passes through an extracorporeal circuit in which toxic compounds in the blood diffuse through a semi-permeable membrane and down the concentration gradient into the dialysate. So, you have an absorption as well as you have a removal to the semi-permeable membrane as well. So, you have a double removal if you are using in combination. Plus, you can correct the electrolytes and also the renal failure. So, your clearance is higher if you use both combination. In certain situations, hemodialysis is more useful than hemoperfusion, especially if your molecule which you are removing is a low molecular weight molecule, less than 500 Daltons, small volume of distribution. Volume of distribution is the toxin which is there in the extracellular compartment, in the intravascular compartment, and the volume is well distributed. Approximately 1.5 liter body surface area fluid distribution can be removed more efficiently if you are using hemodialysis. And molecules which are low protein bound. Now, you understand when you are using dialysis, not removing protein, right. So, we have molecules which are more protein bound, then both the procedure will not be helping you. In such procedures, you have to use higher flux, means you have to increase the pore area, or you have to go to something where you can have a protein removal mechanism. Example is plasmapheresis. So, if you want to remove these molecules which are higher water soluble, which have low protein bound, then you can rapidly diffuse to dialysis membrane. You can also enhance the removal, just I have spoken to you about using high flux or hemodiafiltration, where you can actually use a replacement fluid. In hemofiltration, different from hemodialysis, we are using a replacement fluid. That means we are removing entire plasma and we are replacing the plasma with ultra pure water. And the force which the fluid is removed, that is called as convection. The mechanism in hemofiltration is convection. The mechanism in hemodialysis is osmosis and diffusion. Now, if you are using both combination, hemodialysis and hemoperfusion, the utility is, as I have told you, it is limited to drugs which are in extracellular compartment and drugs which has high lipid solubility and low tissue binding. And these characters are present if you have drugs like tricyclic antidepressant, digoxin, calcium channel blocker, then you will have a difficult time using this modality, because it does not suffice that criteria, removing through hemoperfusion and hemodialysis. That is why most of the studies and meta-analysis have not shown much results using these drugs. So, hemodialysis removes toxin metabolites of methanol, ethylene glycol, corrects acid-base balance, especially if end organ sequelae is there. It increases the rate of elimination of isopropanol, salicylate, theophylline. These are the drugs which has been useful using this combination. In 2015, there was a review which supported the use of hemodialysis for even removing metformin in case of poisoning. Now, this is a long list of drugs which it can be used. You can use hemoperfusion and hemodialysis you can remove these drugs. Contraindication, if you have an active hemorrhage, you have to use heparin. You have to be very careful for this patient. Severe thrombocytopenia, coagulopathy, hypertensive patients, and complication like hypophosphatemia, alkalia, and dialysis dyslipidem syndrome. These are the common complications. Just like any complication of hemodialysis, you can face in this situation also. Now, this is a chart which has actually shown you the level wise concentration of drugs and which one is better to be removed. For example, in phenobarbital, you can use both. In case of paraquat, hemoperfusion has a better performance than hemodialysis. So, this is just a chart I have shown you, the different modalities can be useful. Now, I will just go through few evidence. There are a huge list of evidence on this, and the research is going on since 1970s, but I will just put across some important articles where you can understand what is the evidence if you are using this performance. Now, this comes from the first article there, and this comes from Guy's Hospital, London, and here 15 patients who were severely poisoned with hypnotic drugs or salicylates were treated with charcoal hemoperfusion. That time charcoal was common, and this study this came in 1980s. 2 patients showed no response, eventually died, and the remainder showed lightening in the coma effect and recovered eventually. So, this was the first positive study, though the numbers were very small. Then treatment of severe overdosage with charcoal hemoperfusion. This study came in 1977, and in this study charcoal hemoperfusion was used as a therapeutic aid to actively remove 10 patients intoxicated with variety of drugs. Now, the drugs some places it was known, some places it was not known, and they were all lethal. All 10 patients who ingested the drugs recovered in this study, and one of the 3 patients ingested paraquat survived. So, here the hemoperfusion treatment was associated with demonstrable drug removal, though again a very small group of study. Now, this was a study on the effect of hemoperfusion on paraquat levels, and this study comes from China. Here it was a retrospective study. Out of 105 patients where they had 50 survivors, they actually measured the paraquat level, and they found that paraquat clearance was best in the first 2 hours of hemoperfusion, and after that the hemodialysis had a better result. So, when you are using combination, they had a better effect checking the paraquat levels in these patients. And this was a study where early stage blood purification system for paraquat in a multi-retrospective study. Here basically conservative treatment versus hemoperfusion plus CRRT. These were the 3 arms taken, and in this it showed that hemoperfusion and hemoperfusion with CRRT had a better result on paraquat level, survival of the patient as compared to conventional therapy. And this was an Indian study from South India, where retrospective analysis was were taken from a tertiary medical hospital, and this study was over 3 years. 101 patients were studied, 62 died, and this assessed the golden hour of paraquat poisoning. And this study showed that if you are using paraquat in the first few hours, then your survival rate is better than people who are getting treatment in the later hours. So, early hemoperfusion is helpful in the management of severe paraquat poisoning, and it improves the survival rate. In other studies which we see subsequently, if you are thinking about methanol, ethylene glycol, paracetamol, there the studies have not been very positive because of the sample size. Because even if I see I found one RCT where this was a Cochrane database, we used 11 RCTs which consisted 700 patients. Only one study was there with hemoperfusion, which showed a minimal benefit. So, there the quality reduces. So, actually it is the use of the cartridge which has been in low numbers, that is why we are not getting good positive results. So, there in this study, if you go as per Cochrane database, there is no benefit of charcoal on acetaminophen poisoning. Now, does hemoperfusion in combination with other treatment reduce the mortality? For example, how we have spoken about hemodialysis, conventional therapy. 12 articles were included in this meta-analysis, 1311 patients. It shows that mortality is lesser in hemoperfusion treated patient compared with received only conventional therapy. So, there it also scores better. So, this was what evidence carry, and I will just share some experience of, I will show you the data also. We do something called as hemoperfusion with high flux, high time, high flow dialysis. Now, what is this high time, high flow, high flux dialysis? Now, hemoperfusion is one end running, and from the other end when we are using dialysis, we are using dialysis with a high flux dialyzer, so that the flux can be improved, so that the molecule clearance can be improved. Second, we increase the time of dialysis. Normally, conventionally we are using 4 hours, but here we give 6 hours, so give more time for the poison removal. Number 3, we use high flow. High flow means normally in dialysis we are using 300 ml. In this protocol, I am using around flow of 400 to 450 ml, or the maximum flow which I can attain. So, there the flow increases, the clearance increases, because the number of time the blood crosses the dialyzer also increases. So, this is what I have followed for last 6 years in this hospital, and normally how I start, I do 2 sessions of hemoperfusion and around 5 sessions every day for high flow, high time, high flux dialysis, and these were the results which I attained. I have done 4 paraquat hemoperfusion in this hospital, which consisted hemoperfusion with hemodialysis, and had all survivors. All 4 were survived. Some were even taken 60 ml of paraquat. And to my surprise, I have seen that all the patients whom I have done it beyond 8 hours, beyond 9 hours. I don't know what, I didn't have any mechanism to check paraquat levels over here. So, I went empirically based on the clinical response, and latest one which we have just, we couldn't discharge, he took a DORB, we did 5 hemoperfusion. I followed up that patient on phone, and he went to some other hospital, and now she is at home. And there we reached late, actually we were misguided that she has taken some other poison. When I went into detail, I found that it was paraquat. One patient we did with pregabalin. When we had Debroto and Rajkishore, we used this modality. One we did with telmisartan and amlodipine combination, we had discharged that patient. One case which was my mother, 165 tablets of amitriptyline tramadol, and she is at home happy. But we lost 2 patients. One was a dialysis sister, not from our hospital, and not take the name, and one was our sister. And we bought both patients, and we couldn't do it because of delay referral, or because of the unknown status, or late arrival to the hospital. We lost both. So, you can understand the amount of depression is there in our colleagues. So, that is thing which is, if you see the whole list, a lot of patients are from our own hospital itself. And this was my experience when in government hospital, where I didn't have hemoperfusion. So, I depended only on hemodialysis. I used hemodialysis high flow. I had 1 survivors and 3 deaths. These all were young patient farmers. 2 paraquat experience I had from peripheral center. One was from Krishnanagar. I sent the dialyzer within 6 hours, and that lady survived. Around 40 ml of paraquat she had taken. Both survivors. 3 dialysis, 3 paraquats we lost. 1 young lovers, and they were refused marriage, and they both took paraquat and both died. That also we could just do normal sessions of dialysis, and hemoperfusion we didn't get an opportunity. So, it all depends upon your availability of the things which you have in your hand, the time which you have, the molecule which you have. But the take home message is, appreciate the capability of hemoperfusion as an extracorporeal therapy, and it should be done as early as possible. Early referral to the center, tertiary center, and that is the problem which is happening here, and proper rational use of hemodialysis if possible, with hemodiafiltration if available, and patient should get better chance of survival, best chance of survival if you are using combination of medical, hemoperfusion and hemodialysis. Thank you very much. So, just open for discussion.
I have not seen character patients survive, or the few that I have seen have not survived. It's a while ago, so it's learning to see that there is something that's working. Now, obviously, earlier you used the better. Is there an outer time limit beyond which you would not want to use it?
So there is a clinical time limit. Once you have a pulmonary fibrosis setting in, when the oxygen demands are increasing and we have, then you don't have any chance for doing anything. Number two is because it's a life saving procedure. No, I have used it latest till 5th day, and I had a survival. So frankly, answering your question, I have no answer about how many days actually it can be used. Yeah.
Perhaps just use it.
Use it and see. So you have nothing to lose in situations like this.
Sir, the problem with paraquat poisoning is we have seen that when the patient comes to hospital, they are absolutely normal or have mild symptoms for initial 3 to 4 days. At that point of time, counseling the patient for hemoperfusion is very difficult.
Now see, one thing is very important, that the volume you should assess. What is the volume he is taken, and there you get misguided. And the paraquat poisoning symptoms sets in after 3rd day and 4th day. 5th thing is when you are having a patient which is actually normal, and then you have a situation where things can be abnormal, then you have to convince the patient with data and talk to them that this can be a situation later. So I feel that it should not be taken lightly, and you have to convince and not let the patient, because once you have, because there is a rebound mechanism also, it gets rebound and gets released from the protein. So you can have later symptoms, similarly like in OPC which you are seeing. So you cannot just wait, and then you have nothing to do when you have liver failure, renal failure, lung failure. Then what you are going to achieve?
I'm sure the farmers are aware that this is a lethal poison.
That is the sad part of the story, because none of them is aware. Now you have seen, I have used around 20 cases of paraquat. I have spoken to the family members, and out of them 100% were not aware about the lethality of this. And I'm sorry to say, even the doctors, physicians, they are not aware about it, especially in peripheries and all. They take it as a normal OPC poisoning.
No.
Irreversible thing which they are not understanding.
We are aware that patient, this is a very bad poison.
Yeah, no, taking outside.
Now are aware that you can do something about it.
Yeah.
The issue is that we also need to know, can you do something about it?
So, over and above the conventional treatment, what is the extra cost?
Normally, that is the main problem with the dialyzer. Now there are 2 dialyzers which is available. The one which is a charcoal dialyzer Gambro, which I have just shown you in the first, which is being used from before. The cost of one dialyzer is coming around 10 to 11,000 rupees. And the newer one, which is the resin mode, the cost is higher. The cost is around 28 to 30,000 rupees. So if you see the cost and the life benefit, then definitely this is more. In fact, having that patient in ICU for 5-6 days and then you using this later, it is not going to yield much.
And are you using it in liver failure?
I have not used it yet in liver failure. Liver failure, what I have done is I have done SPADE. It's a sustained pass albumin dialysis, in which we are using albumin instead of dialyzers, and that albumin binds to the protein bilirubin. So that I have used in SPADE, and not over here, that is in my graduation and post-graduation days. But in liver failure, I haven't used it, but it is there. It is a promising therapy which is coming up. We have to see. There are not much studies on it. That's the biggest drawback. So I don't know about that part, but in case of poisoning, we have some studies. So I will definitely recommend to use it when situations like paraquat, where the high mortality is there, to be used.
So usually a single hemoperfusion works, or we need 2 to 3 cycles?
Couple at least, please.
Pardon, sir? Yeah, one hemoperfusion is usually enough, but to enhance the removal, I have used in my therapy 2. But if you go by studies, they say use it as per the urine paraquat levels. Okay, so that is what they recommend. That is the theory.
That's not available.
That's not available, and getting it done, it's a little cumbersome, and it's not available.
So if you think
By the time you lose that golden hour.
yeah, if you think something's maybe bound to protein or tissues and it's going to be released
Later.
after your blood levels have come down from the first one, then you use the second one.
So is there a rough estimate as to one cartridge will remove how many ml of paraquat?
Now normally I had a study which actually removed
The Chinese studies.
yeah, the Chinese study which actually it has gone with the levels. Now it has shown that around 80% of the paracord can come down in the first 2 hours if you are using hemoperfusion. That is what they are claiming. And if you prolong the dialyzer, actually you have more removal if you are using with hemodialysis also. So approximately 80 to 90% removal can be attained if you are using in the first 4 hours itself. But
Do both these work equally? I mean, the charcoal one as well as the...
hemodialysis, charcoal dialysis works better than hemodialysis in first 4 hours. But subsequently hemodialysis is working because charcoal dialysis gets saturated. It reaches a saturation point. 2 hours is the best for its performance, but after those resins gets absorbed, there are molecules sitting on it, it cannot bind more molecules. So it gets saturated. So its effect lowers down. But your hemodialysis is a system where you keep on removing the molecules again and again. So there the constant removal continues. So the graph goes like this. So that is why we are using combination.
And the resin cartridges?
Resin cartridges is the same thing. And the studies which recent one which we had in 2017 was with resin cartridge.
It's like a surface area that gets affected.
Yeah. And that is why you cannot reuse it.
What we are using resin, right?
Where is used here resin? One charcoal we have used because of unavailability, but what we are using here is this charcoal. The problem, the skeleton is weak, so it may break, and that may cause embolism, and they may have allergy reactions.
You do a high flow this thing, charcoal.
High flow, this is innovation which I have done. In fact, I have tried to enhance the dialyzability of the molecule by increasing the flow, increasing the time, increasing the flux, so that, and increasing the surface area of the dialyzer. I use a bigger surface, something like F7 and F8. I am using that dialyzer. So there actually we are using the surface area, we are increasing. So more molecules we can remove.
Good. Thank you.
Any questions, students? We have done recently one with paracord. I know you have not seen it, and we have recently done for one that was for septicemia for one COVID positive patient. So there we, for high interleukin levels, we used it.
What about the human body's physiological molecules in circulation? Do they also basically get removed some of the...
If you engineer a resin with this, you can. It depends upon how is your resin compatible with the molecule which you want to remove. What is the molecular weight of this one? There is no study for that, but if you want to use septicemia hemoperfusion, you can actually remove interleukins, IL-1, IL-6, cytokines. So that can be used.
You know, like digoxin, you can get digoxin antibodies.
Yeah.
So it's similar, even now monoclonal antibodies coming for everything. I wonder if there is going to be a...
Yeah.
And we have bigger things which is polymyxin dialyzers are coming up. So these are the dialyzers where we actually have the impregnation of the antibiotic on the dialyzer, and you can pass the blood through it, and you can have a better efficiency. Similarly, something we can also use it with ECMO also. You can add hemoperfusion with ECMO for septicemia. But again, these things are newer things. You need more studies. It's expensive, so it is not being applied in bigger scale studies because of the cost factor. So you have small group of studies and case series.
But it appears logical.
It appears logical, and in a situation where we have no loss, means you are going to anyway lose the patient. In situation you trying too hard, then things like evidence based, maybe on a back foot and patient want to do it, then you can explain the patient about the benefit and risk and go ahead if they are willing for it. Okay, thank you.